All right, let's begin. All right, everybody, let's gradually wrap up what we're doing and draw your attention toward the monitors or the main demonstration stage. So who would like to have their eyes and ears examined today? All right, so as I've stated, ophthalmoscopy is arguably the most difficult thing that we're going to do this entire trimester. So if you're still a little frustrated, if you're still not really confident in your technique, if you still really haven't seen anything, don't be discouraged. This takes a lot of practice, and as I already mentioned, since we can't dilate the eyes in our scopes, it makes it that much difficult. So as promised, excuse me, as promised, I'm going to step you through exactly what to look for and what abnormal to look for, and give you indications in order of the process of evaluating the eyes in order. Right. So as some of you have already discovered, there are a lot of abnormal findings and a lot of indications that you can identify on ophthalmoscopy if your technique is spot on. Does that make sense? Okay. Christine, I'm Dr. Bodette. I'm going to be looking inside your eyes. So I need you to question. Anybody have any questions? So very first thing you need to do is make sure that your light source works. You're wasting your time and the patient's if you look through the aperture and you say, oh yeah, there's a red reflex when the light source is not on. That's usually when I take out my driver's license to look and see if I was born yesterday. All right, so other things you want to consider, I would start with, if you have multiple settings, I would start with the widest white dot rather than the blue or the slit lamp or the crosshairs on your ophthalmoscope. And also you want to have the intensity of your ophthalmoscope as high as the patient will tolerate. Because if you stay in there a long period of time and you're shining the light in there, it's going to be very uncomfortable. I saw a few people kind of tearing up a little bit. So you want to start at about 28-degree angle and then come in so the patient's not directly staring at the light. So that way, when you work your way from the optic cup disc toward the macula and fovea, that's the only time when you're going to be straight on. Make sense? Additionally, if you're examining the patient's right eye, you need to look through the ophthalmoscope with your right eye and vice versa for the left. Why is that? Because if you're using a traditional ophthalmoscope that's not the Welch Allyn PanOptic or other more sophisticated pieces of equipment, as close as you need to be, you run the risk of possibly making your mask had contact with hers. And that is, so you don't want to be looking through the left and examining their right, because you're going to be right in front and your lips might touch, and that's not good for business. That was kind of a joke, but also kind of serious. All right, instructions. I'm Dr. Bodette. What I'm going to have you do is keep your head still and focus on a point in the distance. Try not to move your eyes too much. Okay, first step, make sure your light source works. And I'm going to be looking through my right. And I'm going to focus on my hand to start with. And then I'm going to have my hand on the, oops, I'm going to have my hand on the diopters so I can refocus. Now, very first thing that you should see when you shine the light source on her eye is sort of a orangish glow right there in the middle of the pupil. What you're actually seeing is a reflection of the light off the retina. And this is what's called the red light reflex. You're probably thinking, well, it's not red, it's almost orange. Well, I didn't make up the term. It's called the red reflex. So that's normal. You should see a red reflex. If you do not, that could mean one of two things. Number one, it could be a nuclear cataract, which is obstructing that light from hitting the retina, or it could be an eye prosthesis. Maybe they had a retinoblastoma or another severe trauma to the eye that required sort of a prosthetic eye. Make sense? So that's the very first abnormality that you want to look for. Now, once you see that red, then you're going to be coming in at that angle. And then the closer you get, you want to refocus to posterior structures. And you want to go very slow until the first thing you see are arteries and veins. And they're gonna pop into focus. So let's talk about the arteries and veins. They should be of normal consistency. There shouldn't be bursting blood vessels. There shouldn't be neovascularization, those small little blood vessels I showed. There shouldn't be cotton wool patches, things like that. And additionally, the artery and vein shouldn't be on top of one another, almost like it's discontinued. That's going to be what's called arteriovenous nicking. All of these are indicative of retinopathy, either due to chronic hypertension or uncontrolled diabetes mellitus. Everybody with me? So once you find those arteries, the next step is to trace the arteries and veins into the optic cup and the optic disc. So what are some pathologies associated with the optic cup and the optic disc? Well, if both the optic cup and the optic disc appears magnified, then that could be papilledema due to increased intracranial pressure due to head trauma and leading toward encephalopathy or hemorrhage. If the margin of the cup approaches the disc, that's consistent with glaucoma, increased intraocular pressure. Make sense? Then, last step. You're going to work yourself medial to visualize the macula and the fovea. You might see that yellowish debris coming off the macula. That would be consistent with age-related macular degeneration. You also want to look at the integrity of the retina itself. Is it jagged? Is it irregular? That could be indicative of a retinal detachment. Both of those result in central vision loss just because of their position relative to the optic cup and the optic disc. So that's pretty much it. We're going to be looking for you to change focus coming from anterior to posterior. And since we can't dilate the eyes, if you're too far away or you don't move yourself around, it's not going to be feasible for you to visualize everything. Now, don't get me wrong, it's very hard for us to see exactly what you see on this exam. In fact, when I say very hard, it's almost impossible. So my advice to you is follow the steps as I just demonstrated, and based on your knowledge of what to look for, just make it look good. Any questions? Want to do every test bilaterally and start with the unbiased side first at all times. I'm going to do everything on the left eye. I have trouble looking out my left eye and squinting my right. So what I do normally is I hold the ophthalmoscope with my left hand, and I'm physically going to close my right eye so that way I can look through. So first step, what am I looking at? So red reflex first. If you can see the red, that's a good first step. If I don't see a red, what does that mean? Could be a nuclear cataract that I'd see on visual inspection, or it could be an eye prosthesis. Next step, you're going to work your way closer and you're going to refocus so that you can see an artery and a vein just pop. Pathologies associated with the arteries and veins are arteriovenous nicking, microaneurysms, hemorrhages, exudates. Next, you're going to look for the optic cup and the optic disc. The cup should be about a third the margin of the diameter of the disc. If it's larger, it could be glaucoma. If everything is magnified, it's papilledema. Then you're going to look at the macula and fovea. Is there drusen? That could be macular degeneration. Is it jagged? Is it irregular? That's retinal detachment. What is drusen? That's a term for that yellowish discoloration that kind of resembled a cotton wool patch. Drusen is to age-related macular degeneration as cotton wool patches are to diabetes mellitus. Remember now? So that's pretty much it. Any questions? So it's 10:32. So I can turn the lights down to make it a little easier for you to see. And I can give you time to struggle through this one more time. Or I can demonstrate otoscopy. You want to see otoscopy before I give you a chance to practice anything? Okay, works for me. Okay. Just give me a second here. Everybody see what I'm doing? I'm cleaning my equipment in front of the patient. If you're using permanent specula, then you want to make sure and clean using alcohol. If you're using disposable one, obviously just pop that in the garbage. Okay. Complaints on the, you can help me out a little, Christine. Could you move a little closer to the edge of the table? I don't think my cord's going to reach the left. Okay. We are all set to go. You okay with this? Right. I'm going to be, Christine, I'm Dr. Bodette. I'm going to be looking inside your ears. So just relax and breathe normal. Try and keep your head still. Do you have to say those words on instructions? So occasionally I've had students say, could I record what you just said? That's a little overboard. Just give the patient a little bit of heads up about what they're about to experience. You run into difficulties if you remember, number one, say nothing, or number two, say way too much. Oh my God, if I stick this too far, let me know. All right, so anatomically, how do I position the ear? I need to pull the pinna of the ear up and back if it's a younger to middle-aged person. If it's a child, it's a little different. I think it's just straight back. That sound right? I don't like kids. Anyway, so up and back for adults. I like to hold the otoscope like sort of like a pencil, and that helps me kind of use my cheek, or my cheek, my hypothelial arm, and it's on her cheek, so I know not to insert the speculum too far. Make sense? All right, ready? So you can do that too. If you're not comfortable doing that, then there's nothing stopping you from holding it like so, but we are going to be looking for you to pull the pin up and back. Make sense? Needless to say, this instrument needs to be on. Oh yeah, there's the cone of light, and you didn't turn it on. Come on. How can there be a cone of light if there's no light? I've seen some stuff over the years. So anyway, what am I looking for? Well, normally speaking, it should be sort of a pinkish hue. There shouldn't be excessive cerumen. Where should the cone of light be? Very good. So it should be anterior, inferior. Make sense? So once you find the cone of light, then you can trace that up to the umbo of the malleus and the other landmarks, pars flaccida, pars tensa, on the eardrum itself. Does that make sense? So you can look at the integrity of the eardrum. Sometimes you might see the damage there. What if the cone of light is not anterior, inferior? What if it's in a different place? What does that mean? Say what, Sean? Okay, so yeah, we turned it on because the cone of light's in a different place. So how do you explain that? So maybe the eardrum is bulging, so it's reflecting in a different spot. Right? Bulging tympanic membrane usually happens secondary to chronic middle ear infections. Would a protrusion affect it? Protrusion of what? So yeah, so if there's a foreign object in there, you may not be able to see the cone of light at all. That foreign object, regardless of what it is, may be blocking it. That's good. The absent cone of light could mean obstruction, sure. So that's pretty much it. Abnormals, it could be excessively red. There could be effusion. That could be an infected middle or external ear. There could be discolorations, foreign objects, excessive cerumen, and problems or damage to the eardrum itself, altering the position of the cone of light and possibly having physical damage to the tympanic membrane. We can't really see anything past that. You might be able to see a glomus tumor if in fact it was the middle ear, but just like acoustic neuroma, they tend to affect the inner ear more often than not. So don't worry about that one. One to derive just bilaterally, start with the emulsite first at all times. So everything the opposite on the patient's left. Cone of light's going to be anterior, inferior, in this case about 7 o'clock. And everything else is opposite. Suppose you're right-handed and you're not confident holding it with holding the otoscope with your left hand like I am. That's perfectly fine. If you want to hold it with your right and bring your left hand up so you can pull it up and back, that's perfectly fine too. Make sense? So that's pretty much it. Then my machine here, all I have to do is just put it back down in its spot and it turns off. And you probably also want to get into the habit of cleaning it right before and after, which I'm going to do right now. So it's real easy to insert too far. So whatever precautions you can make to not only see everything, but also make sure the patient's nice and safe, we're going to be watching for. So hopefully this gives you a little bit more of a what's the word I'm looking for? More of a detailed sort of a stepwise manner in which what to look for and what might be some reasons to cause these problems, rather than just kind of mindlessly going, oh yeah. So it is about 20 till. So let's take the next 10 minutes. I'm going to dim the lights to make it a little easier for ophthalmoscopy. And then we'll, if all goes well, we'll pick up with probably just rhinoscopy in the second hour. All right. Let's gradually bring our attention to the main demonstration stage of the monitors, and let's talk about the nose and sinuses. I'm gonna dry my hands a little better. All right, who would like to have their nose and sinus evaluated today? Anyone? Anyone at all?
You know where to get the plastic cover for this? I will.
The answer is no, I don't. Okay, Usman. Gonna go ahead and I'm not gonna use this yet, but I'm gonna go ahead and clean it in front of you. Okay. Nasal palpation and rhinoscopy. I would get into the habit of not only palpating the nose before evaluating it, but I would also get a sense on whether or not there might be any possible obstructions before inserting the specula. So here are some strategies with which to do that. Everybody okay? All right, Usman, I'm Dr. Baudet. I'm going to be taking my hands and making contact with your nose. I'm also going to use my instrument to look inside best you can. Just keep your head still when I tell you. Lower your mask and cover your mouth. So what I'd like you to do, complaints on the left, we're going to start on the right. What I'd like you to do is take one finger, take your left index finger, cover your left nostril, and breathe in and out through your right nose. Any pain with that? Left side? Pain with that? Do you have to have them breathe in and out through the nose before performing nasal palpation? The answer is no. It's something that I've kind of picked up just to give me a little bit of clue as to what I might encounter when I do perform otoscopy. All right, so next thing I'm going to do is I'm going to take my hands. I'm just going to be making contact with areas of your nose. So at any point it hurts, just let me know. You want to palpate the cartilage first, and then just go straight down the bridge of the nose. Any pain with that? Okay. So that's really all there is to it. Pain could indicate, or possible deformity on visual inspection could mean pretty significant trauma, bar fight, rhinoscopy gone bad, who knows? Rhinoplasty gone bad, I should say. Rhinoscopy haven't done yet. Don't even laugh at the bad jokes I tell. Could you get a little closer to my apparatus here? All right, so a couple of things we're going to be looking for on your performance of rhinoscopy. Number one, want to have the patient seated. If you're not very tall and your patient is, then put them on a stool to make it easy for yourself, but they probably need to be in the seated position. So, and patient position is going to be important. We're going to have the patient's head back in extension slightly. And before inserting the otoscope, you're going to take one finger and you're going to press the tip of the nose in like so. So what's the purpose of doing this? Does it matter? Well, I wouldn't ask you to do that if it didn't matter. So the whole point of having the patient's head in extension and pressing the tip of the nose in is to widen the nostrils even further, to make it a little bit less uncomfortable for you to insert the speculum. So head and extension, press the tip of the nose in to widen the nares. Everybody got that? Okay. Right, so now we're ready to go. Complaints on the left, we're going to start on the right. I'm going to put your head back. I'm going to press in like so, and I'm going to look inside. Same with that. Want to do it just bilaterally and start with on the ball side first of all times. Otoscopy, patient seated, head back and extension, press the nares in, insert the specula very gently. If you don't have a rhinoscope, you can use your otoscope. I would recommend using the widest specula you have to make that, to minimize kind of moving yourself around in order to visualize everything. So what should a normal nasal otoscopy actually look like? So what first thing you want to look at is the color of the nasal mucosa. What color should it be? Should be a pinkish hue. If it's not, and it's excessively red, that could mean an infection. If it's sort of a light bluish color, that could mean seasonal allergies or hay fever. We also want to look at the integrity of the septum itself, and we want to look at the turbinates. Right? Obviously, the septum is medial, the turbinates are lateral. Or are they? Yes, they are. You studied anatomy sooner, more recently than I have. So what could be wrong with the septum? It could be deviated. You might be able to see that on visual inspection. It could be perforated. What could that indicate? Well, most likely it's going to be a bad batch from a disreputable street pharmacist, because it's unlikely that there's going to be trauma with like a very pinpoint, you know what I'm trying to say, pinpoint small little circle. What about piercing? So piercing might have a pretty substantial hole right there in the septum. Might cause a sort of a whistling sound if in fact somebody tried to breathe in and out through their nose, things like that. So what could be wrong with the turbinates? So so another thing you want to look for them. So polyps could be there. They could also be anywhere, including the sinuses. If in fact you do see a big honking polyp, should you be concerned? Well, the larger it is, the more likely it's probably precancerous. So probably will require a pathological analysis or a biopsy. Make sense? Okay. What part of what bone is the superior nasal turbinate? So it's part of the ethmoid, correct? What part of what bone is the inferior nasal turbinate? That's the one that it's on. That will come up on your national boards. Did you already take part one? That again? Sure. Superior middle nasal turbinate. What cranial bone is it part of? The ethmoid. Inferior nasal turbinate. What part of what bone is it part of? It's its own bone. Does that answer your question, Christina? Excellent. Any other questions? So if you go stepwise, you're looking at the color first. You're looking for integrity of the septum, then you're looking for integrity of the turbinates. And after I go through this in lecture, might get to it Friday after lymph nodes, but hopefully it'll make more sense to you. I suppose I could quickly do transillumination. Let me clean this again. We are really flying through this material this trimester. It'll give us a lot of flexibility to do other things. All right, sinus palpation and transillumination. When would you perform this? Every patient? Right. So if they're complaining of facial pain or pressure inside their face, very good. Or if they're getting over an infection, or if they're just complaining of discomfort in and around their face. So there are only, based on position and anatomy, there's only two sinuses that we can effectively evaluate, and that would be frontal and maxillary. Ethmoid are a little too central, and sphenoid, I don't want to do a cross section of his head. That would be permanent. All right, Usman, I'm Dr. Burdett. First thing I'm going to be doing is taking my thumbs and making contact with various areas of your face. So let me know if this hurts or is uncomfortable in any way. Does it hurt? How about any of that? Does that hurt? So that wasn't uncomfortable for him. If in fact he reported that it was sort of an increase in pressure with making contact with the areas of the sinus, that could be indicative of possible sinus infection. If there's a difference bilaterally or a difference on one side compared to the other, that might be consistent with asymmetry on transillumination, which is why I want to palpate the sinuses before trying to illuminate them. Make sense? Okay, now we're ready to illuminate. Now, this procedure is pretty difficult, particularly the maxillary sinus. So as dark of the environment that you can make it will help you. Obviously, you don't want to be too dark, so you don't poke them in the eye with your speculum. But the darker you can make the environment, the better it will be for visualizing the frontal and the maxillary sinuses, particularly the maxillary. Okay, plane's on the left, and start on the right. Okay, what I'm going to do is I'm just going to angle my light source up, starting with your right, underneath your just above your eyeball, but underneath your brow. So just relax and be normal. Painful? Painful? Okay. Want to do every test bilaterally and start with on the Bob side first at all times. Frontal sinus transillumination, patient seated. You want to angle, in this case, my otoscope specula, which has been cleaned, you want to angle it inferior to superior above the brow, but you don't want to just take the skin. You don't want to just light the skin. You don't, that will make it, can you zoom in? Yeah, get in here, please. No, you're good. You're good, Usman. Okay, never mind. So you want to angle it, but not just take the skin. You want to make sure that you're underneath the orbit. And inch your otoscope specula. That's fine. Thank you, Dr. Alfaro. And you want to inch the specula so you can get all of the sinus or as much of it as possible. And it is, as much as I'm trying to shield the light, it's still a little bit hard to visualize. So before I get to maxillary, what we're primarily trying to find here is any asymmetry on one side compared to the other. So what could that asymmetry be? Well, it could be, in the case of an infected sinus, there could be a fluid line on one side. There may not be on the opposite side. Or you might even, I've never seen this myself, but you might even see the outline of a polyp. Okay? So, but polyps tend to live primarily in the nose compared to the sinuses. Okay, so maxillary is pretty tricky. Here's how it's done. So you're going to angle your otoscope specula, in this case, superior to inferior. And when I tell you, I'd like you to open your mouth. When I tell you. Thanks. So the first step is kind of angle the specula superior to inferior. And then the next step is you want to look at the roof of the mouth through the mouth open to see if you can see a light. So open your mouth, please. And this is exactly what Bates describes to do. And I think on one student, I was able to see something through the mouth. So maxillary is a lot more difficult than frontal and frontal. Okay. So repeat on the left. Patient seated. We're going to angle the otoscope speculum superior to inferior at the zygomatic process, and you want to inch from medial to lateral. And then you want to have the patient open their mouth and look in the roof of the mouth to see if there's any discoloration. Actually, you know what? I see it. Congratulations. So again, we're primarily on this one, we're interested in finding asymmetry on one side compared to the other. And that asymmetry could be the outline of a polyp, could be a fluid line on one side, depending on where the area of pressure is and where the infection kind of landed. So that's transillumination. In regard to ophthalmoscopy, in comparison to ophthalmoscopy, I would say that the illumination of the maxillary sinus is just as complicated, if in fact a little bit more. So if you don't see anything and they don't have any, they're not complaining of any facial pain, they don't look the picture of an infection, that's another procedure that you can kind of skip. Just recognize, just like all of the eyes, ears, nose, throat procedures, just recognize what type of patient complaints would tell you, you know what, I need to go ahead and do this. Because it's not going to be everybody. Any questions? If no questions, it is 22 after, so let's spend the rest of the period kind of running through all four of these. Thanks.